So what I'm going to do in the next 10 minutes is discuss how we can interpret a decade of randomized TAVI trials and integrate into our clinical practice and recommendations. These are my potential conflicts, and this is an overview of the landscape of randomized TAVI trials. And what is clearly visible is that we see a creep in age and also in risk profile of the patient. So on the left-hand side of the screen, you will see the high risk and the inoperable patients with a mean age well above 80 years old and an STS score well above 5. And then on the other end of the spectrum, you see a mean age of below 75 years old and an STS score of less than 2. So these are the highlights of the landmark TAVI trials. On the upper left-hand side, you see the inoperable risk patient trial, the partner cohort B, which demonstrated an 20% absolute reduction in mortality in patients who were treated with TAVI over conventional medical treatment. That was unseen for up to that moment. On the upper right-hand side, you see the high-risk trial with the core valve system. That was the first trial that demonstrated some kind of superiority of TAVI over surgical aortic valve replacement in a selected set of high-risk patients. So this is a typical effect what you can expect with TAVI over surgery, and that you can consider it to be a class effect. With TAVI, patients will improve faster. Their quality of life is improving within 30 days. With SAVR, with surgical aortic valve replacement, that will take a little bit more time, but you do see after 6 months that the kind of improvement in quality of life will be similar between TAVI and surgical aortic valve replacement. That said, recent data from the SUR-TAVI trial, that was a randomized trial on intermediate risk patients, clearly demonstrated that patients who received TAVI were also functionally improving. So when you look at the 6-minute walk test, it immediately improved within 30 days, whereas the 6-minute walk test was deteriorating after surgery. At 1 year, after 1 year of follow-up, there was still this maintained improvement after TAVI. The surgical cohort also was improving, but the net benefit in terms of 6-minute walk test, so the functional capacity of patients, was better with TAVI over surgery. So let's go to the partner 2 intermediate risk trial data that were recently described at 5 years follow-up. This was presented in the New England Journal a couple of weeks ago. And what I wanted to highlight here is that if you compare the transfemoral and the transapical cohorts with surgery, there is a difference. The transfemoral TAVI cohort was similar to surgery out to 5 years. But on the right-hand side, you can clearly see that the patients who underwent a transapical TAVI were doing worse at 5 years as compared to surgery. So access side and access approach does matter with transcatheter aortic valve replacement. And that brings me to the low-risk trials. There were 2 big low-risk trials that were presented and published last year. The first one was the partner 3 trial. What you can see on the upper left panel is that there was a significant reduction in a composite of mortality, stroke, and hospitalizations in favor of TAVI over surgery. And mind you, these were patients with an average age below 75 years old and with an STS score below 2. If you then look at the individual components of the endpoint, also those components were numerically better in the patients who underwent TAVI. And this is also the same thing was echoed in the Evolute low risk trial. And this slide summarizes basically all the endpoints, all the important endpoints that patients will experience within the first 30 days. And what you see is that basically everything seems to be moving in favor of TAVI, except the pacemaker implantation. And we will discuss pacemakers and conduction disorders later, but that with some of the device platforms with TAVI, there is this issue with pacemakers, but we'll get to that later. So if you look at the major endpoint breakdown within the Evolute low-risk trial, and this is quite illustrative what's happening there between TAVI and surgery out to 1 year. You see that the mortality is numerically lower with TAVI, but there was no significant difference. But if you then also add stroke, then all of a sudden the difference between the two interventions seems to increase. And if you then add rehospitalizations, which I acknowledge is a softer endpoint, but then the difference becomes really important. And I do believe that mortality, stroke, and hospitalizations are the endpoints that really matter to the patients that we are treating nowadays. If we then briefly zoom into the cause of death within 30 days, then in a low-risk trial as the Evolute low risk, then patients who underwent TAVI, they were dying because of coronary obstructions or aortic dissections, whereas the patients in the surgical arm were dying because of overall cardiac arrest, multi-organ failure, hypoxic brain injury. And it seems to me that some of the issues, the catastrophes with TAVI, they may be amenable and addressable with better, improved planning and maybe with a patient-tailored valve selection. But I question whether we can say the same thing for surgical aortic valve replacement. So I'm thinking that the impact of open heart surgery just is too much sometimes for patients, even at a low operative risk. But we have to be careful with the interpretation and with over-interpretation of low-risk trials, because the two randomized low-risk trials so far screened a lot of patients, but 85% of the patients that were screened ended up in the trial, and there was no coronary artery disease. Ejection fraction of those patients was above 60%. There were no failing bioprosthesis, and of course bicuspid aortic stenosis, which is another topic that we dive into later on, was excluded from these trials. I think one word on durability. The NOTION trial has follow-up data out to 6 years. The NOTION trial was a small trial in Scandinavia led by Lars Søndergaard, comparing core valve, a first-generation TAVI system, with surgery. And they had, at 6 years of follow-up, they did not see a difference in bioprosthetic valve failure. So that means that there was no signal in favor or as a disadvantage for TAVI versus surgery. But if you look at the early stages of structural valve deterioration, then it seemed that the surgical component, the surgical bioprosthesis, showed earlier signs of valve deterioration as opposed to the TAVI valves. And that might be due to the superior hemodynamic performance of the valves, but this was a small study, so it is hypothesis generating, but it is at least intriguing. And I think it is important to note that the randomized trials that have been completed at this day and age, they will have 10 years of follow-up. So 10 years from now, we will have a core lab echo assessment that will definitely shed new light to the durability issue between TAVI and surgery. I think this leads me to the last slide, which is, I think, a very important one in 2020. When we have a heart team discussion, what has changed over the last couple of years is that also the opinion of the patient matters. Our patients, they need to be informed and they need to be able to come to a conclusion for themselves based on that information. And make no mistake, a lot of the patients, they are Googling what's going on in aortic stenosis, they know what's happening there, and they already have an opinion. So we need to have an open discussion with these patients to come to individualized therapy. So to conclude, I can say that TAVI can replace conventional surgery for aortic stenosis, and it is already a reality in elderly patients across the risk spectrum. I think an important subset of patients requires further study, for instance, bicuspid patients, failing bioprosthesis, younger patients, concomitant coronary artery disease, concomitant valve disease. But I think it's fair to say that in 2020, this is the era of precision medicine and shared decision-making. The preference of the informed patient matters. With that, I give the word back to Roxana.
I have a question for you. Thank you so much, Nicolas. This was fantastic. And thank you for your presentation. I wanted to just kind of come back to you and ask you a question specific to your last slide on precision medicine and shared decision-making, a very important point. So how do you actually do it? Do you actually sit there with your patient? Tell us how you take your patient through the risks and benefits of SAVR versus TAVR and how you make those decisions with the patient.
I think this is an important matter at this day and age. In the elderly patients at a high operative risk, the time that you need to spend to explain the benefits of TAVI over surgery is limited. But in the younger patients, because there are still unknowns and we have to be open about it, you need to spend a little bit more time to discuss what are the benefits in the short term and what are the unknowns down the stretch. So I do give a lot of attention to that, and as a matter of fact, we also discuss it in our multidisciplinary heart team discussion. The patient's opinion matters.
So really good. So let me just go to Lars directly, because I think the question of durability, valve durability, is a very important one that we have to talk to, especially when we have a low-risk patient. The NOTION trial showed no difference, perhaps, over a pretty long period of time, as long as we have it. But the recent studies, the partner studies, started to kind of change the narrative a little bit, showing a little bit of a later catch-up for TAVR. What do you say to that? Any of you, but let's start with Lars. How's that different than NOTION?
I think if you look at it in a very simple way, you give the patient a new valve, you open the orifice of the aortic valve, and as it's going to degenerate, you're going to lose some of this area every year. So if you start at a higher level, it's probably going to take a longer time before you meet this criteria of valve failure. And the difference between the NOTION trial and the Partner 2 trial that was that in the NOTION trial, we used a core valve platform, a self-expanding technology with suprannular position of the leaflets, which we know provide a larger opening area than a balloon expandable valve with an interannular leaflet position. So I think that could be the main driver why you see these differences. But again, it's very complex to choose the right valve for the individual patient. You have to look at all the spectrum. Durability is, of course, one very important part if you move to a patient with a longer life expectancy.
So Didier, how do you choose valves?
I think Lars was right. Durability is probably one of the main issues. So the age of the patient may play a role. But when it comes to valve selection, it's more about the anatomical factors and some of the ECG factors from the patients. Is there a high risk of further need for coronary cannulation in the future? Is there a risk of a high annulus rupture, of AV block, things like that? And this is going to impact our final choice. But at the end of the day, I do believe that on a contemporary manner in a large volume center, we should be able to use at least 2 or 3 valves to be able to tailor the valve type to the patient.
So you do have this tailoring, and you do believe then, Azeem, do you agree to that we should have more than 2 valves, or should we have 3 or 4 valves on the shelf? How many valves on the shelves should we have, Azeem, and how many do you have at Montefiore?
Yeah, no, that's a great question. I think the number of valves you have on the shelf depends really on your experience and volume and your center. I think any sort of decent TAVR center that's doing at least 100 cases a year should have at least 2 valves with 2 very different mechanisms of action. So, ideally you want to have a self-expandable valve and a balloon expandable valve. In more experienced centers, I do believe you need more valves, because you then in a more experienced center will be dealing with more complex patients. You end up being a referral center for other smaller centers who send you their more challenging patients. So we do need to tailor it, and I agree with Lars and Didier. I guess the challenge is how do you be consistent on how you tailor, right? Because what Didier may consider suitable for a self-expandable valve, maybe I would say I would prefer a balloon expandable valve. So there is some inconsistency in how we tailor. So what I would love to see in the future, and I think Nicolas kind of hinted to it a little bit in his slide, is that I would love to see more patient-specific modeling so that we can take the patient's CAT scan and model what different valves would look like if we put it in that patient, and then come up with this valve actually with this anatomy would give you the best possible outcome. That's what I think we need to see in the future.
Well, I think I agree with that, and I don't know why we're not doing more of that. And I know, Kendra, you at Emory, you guys have a lot of innovative ways of kind of looking at this. How are you choosing which valve for which patient, and are you integrally involved as a surgeon in this discussion?
Absolutely. I think that what Azeem hit on is really the next frontier of imaging these patients and being able to select a valve appropriate for that particular patient. One of the things we focus mainly on during our heart team meetings is the lifetime management of these patients. Especially as the patients get younger, it's going to be important that we pick an initial platform that we can build on. So whether that initial platform is a TAVR, planning on another TAVR, and eventually then open heart surgery, or do you start with open heart surgery? I think there are anatomic considerations as well as patient characteristics and medical history that play into all of this. Much of our decision is based on age, but like Azeem said, we should be modeling these. We use CT reconstructions, but maybe 3D imaging is the answer.
No, I love that. I love this next way of how we're going to choose which valve for which patient. So before you leave, Nicolas, parting words on this lifetime management of patients with aortic stenosis. What do you think about that? I love that comment from Kendra.
I think a lot of people talk about it, but I think there is an elephant in the room, and that is redo surgery after a TAVR or a TAVI. I think if a patient underwent TAVI and then needs some kind of new therapy 10 years down the road, then of course that TAVI valve is embedded in the anatomy. It's scarred. I don't think it's going to be easy surgery. So this is, I think, an important challenge for our surgical colleagues. They need to be technically very good. They need to know how to do root repairs, and this is more challenging than it seems at first glance. So I believe that a lot of those patients who require an operation after a TAVI procedure will require root reconstructions in order to get a new valve. So Kendra, can you comment on that? Do you expect that will be frequent?
Well, I think that that's kind of an unknown, and currently there is a multi-center investigation. It's a retrospective, but they're looking at exactly that. How difficult is it when we go back and intervene? Sometimes it's quite easy, and the valve comes right out. You're right, it's not incorporated into the aortic wall. Fortunately, you have the native leaflets, and so that's somewhat protective because you can peel away from the native leaflets that if you're doing an open surgery, those still have to be cut out. So you have a little bit of a buffer. But you're right, if we've significantly oversized it, if it's touching the aorta or embedded in the aorta, now you've turned a surgical aortic valve replacement, which is a fairly straightforward operation, into possibly a full root and maybe even an ascending. So we don't know the answer yet. I figure that's what I'll spend the rest of my career doing.
Professor Lars Søndergaard, who's going to talk to us about the conduction conundrum in TAVR. Professor Lars Søndergaard.
Thank you, Roxana. So ever since the TAVI started, one of the Achilles heel has been conduction abnormality, and it's still one of the things we have to consider as we move to patients with longer life expectancy. And the reason is that we have the first question we had when we started was, did these conduction abnormalities have any impact on the clinical outcome of the patient? And we didn't see that in the beginning when we were treating elderly patients with limited life expectancy. But we have now seen consistent evidence that it's going to impact the outcome of the patient. So this is a meta-analysis with almost 8,000 patients who received a new permanent pacemaker after a TAVI procedure, looking at the outcome at 1 year. And you can see the patient who received a new permanent pacemaker had an increased all-cause mortality and also an increased rate of heart failure hospitalization. And also even more frequent than to have a permanent pacemaker is to have a new onset left bundle branch block. And again, from the same meta-analysis, more than 40,000 patients, you can see that a new onset left bundle branch block is not a benign complication after a TAVI. It's associated with an increased all-cause mortality, cardiac mortality, heart failure hospitalization, and later on permanent pacemaker. So you can ask yourself, is it possible before the procedure to try to make a risk stratification for conduction abnormality? And of course, you can look at the patient's ECG, but we also know that the anatomy will mean something. So the reason that pacemaker or conduction abnormality is quite frequently after TAVI is there is a close proximity between the aortic annulus and the AV node. As illustrated here in this cartoon, you can see between the right and the non-coronary cusp, you have the membranous septum, and just below the membranous septum, you have the AV node, and thereby also the risk if you implant your valve too deep that you're going to compress it and have conduction abnormality. And we also know that all the patients have a CT scan before the TAVI procedure, but you can actually, on some of these CT scans, if you have contrast in both the right and the left side of the heart, look at the membranous septum and actually measure the length of it. So it's nicely illustrated here on the right-hand side, what is the length of a membranous septum, and also you can see this superimposed cartoon on the conduction system. So again, if you exceed that length, there's a high risk that the patient is coming out of the cath lab with a new onset left bundle branch block or even a third-degree AV block with the need for a permanent pacemaker. And it's also discussed where to measure the membranous septum. And this is one study we did in Copenhagen. And you can see the membranous septum sitting again below the non-coronary and the right coronary cusp. And the point where it's actually have the shortest distance is just right under the right coronary cusp. And also we know if you look at the CT scan after a TAVI procedure, the TAVI stent frame is often sittest at its deepest position under the right coronary cusp. So this is probably where you should measure it up front to try to make a risk stratification for the individual patient for having a conduction abnormality, and also try to plan your procedure. How high or how deep can you actually implant your TAVI valve in this individual patient before you have conduction abnormalities? There's also a lot of, this is just one illustration here. This is a patient, two patients having a valve implantation at 8 millimeter of depth, and you can see one have a membranous septum length of 3 millimeter coming out with a third-degree AV block and a need for a permanent pacemaker. The one on the bottom have a much longer membranous septum, 12.8 millimeter. There's no conduction abnormality. So again, it can be used for risk stratification to measure that prior to the procedure, the length of the membranous septum. And also we know there's a new implantation techniques everyone is talking about. How can you actually use this implantation technique to reduce the conduction abnormality? So everyone knows that on echocardiography, you can have different chamber view. You can have a 1-chamber view, 2-chamber view, 3-chamber view, and 4-chamber view. And most of you who's doing echocardiography know that if you want these views, where to place your echo probe to actually to get this. And the reason I'm showing this is that you can actually do the same in your cath lab with your patient on the table. So if you look at this, this CT scan, which is on the right-hand side, transform into what you actually see in the cath lab, you can, in the play with your C-arm, you can go REO, LAO, cranial, caudal, and mostly doing the TAVI implantation in an LAO cranial projection. But you can see here, if you go as in this, if you go LAO caudal, you get a 4-chamber view. If you move to LAO cranial, the most used implantation technique, sorry, you have a 4-chamber view. If you go REO cranial, it's a 2-chamber view. And very important, if you go down to REO caudal, as you're going to see in a minute, you're going to have a 3-chamber view and a much more open left ventricular outflow tract. Back again here to LAO caudal, a 1-chamber view, and LAO cranial, which is used to be the most used implantation technique, you have a 4-chamber view. So keeping this in mind, that you can have different here, just summarized, REO caudal is a 3-chamber view with the elongation of the left ventricular outflow tract. The conventional LAO cranial is a 4-chamber view. And what you also want, you see this is going to be different from all patients, and you can use CT planning get this S-curve, which is going to say where are the three cusps aligned. And that's going to be different from patient to patient. But what you ideal want during the implantation is not only to have the three cusps aligned, because that's often going to give you the delivery system not aligned with the imaging plane. And if you adjust the imaging plane in the cath lab to have the delivery system aligned, you often end up in a situation where the three cusps are not aligned. So ideal, you want to have both the three cusps and the delivery system aligned with the imaging plane. That gives you a much better understanding how deep or how high are you during your valve implantation. And going back to this S-curve you saw before, what you can get from the Tremencio report is the yellow S-curve telling all the projection where you have the three aortic cusps aligned. You can actually have the same for the delivery system, in which projection are this aligned with the imaging plane. Most of us do not have this software for where the delivery system is aligned, but one thing which is very important to remember is that these two S-curves is almost always crossing each other in an REO caudal projection. So if you in the cath lab try to search REO 20, caudal 20, 30, and you see the delivery system aligned, you have a high chance that you're also going to have the three cusps aligned, and thereby you have both aligned and a better implantation technique to understand how deep or how high are you. And as I said before, one additional, this is just one example here, you can see in REO caudal, you can see that both the three cusps are aligned and the delivery system is aligned. And one additional feature to using the REO caudal projection instead of the LAO cranial is that you're going to open up for the left ventricular outflow tract. That's going to be elongated instead of shortened as in the conventional. So that's why it's recommended nowadays to do your valve implantation in an REO caudal projection instead of an LAO cranial projection. So one question is also, if you're coming out of the cath lab with a new onset left bundle branch block, when to implant a permanent pacemaker. And we did this study here and coming out with a very simple algorithm. If the patient is in sinus rhythm, you have a QRS duration less than 150 milliseconds, you can remove the pace lead. This patient is not going to need a permanent pacemaker. Atrial fibrillation is 140 milliseconds. One thing which is more complicated is patients who have a pre-existing right bundle branch block. We know these patients have an increased mortality just after TAVI, just after discharge. And if you give those patients a permanent pacemaker, it's going to be for the same mortality as for patients without pre-existing right bundle branch block. So just to summarize here, TAVI and conduction abnormality impact the patient outcome with increased mortality and rate of rehospitalization. It can be reduced by higher stent frame implantation, and implantation depth can be tailored to the individual patient by measuring the length of remembrance septum on the CT scan before the procedure. Using an REO caudal projection is going to bring the aortic cusp and the delivery system aligned with the imaging plane, as well as it'll open up for the left ventricular outflow tract to better understand the depth of the valve implantation. And there's now simple algorithm which can tell you when to implant a permanent pacemaker in patients who have a new onset left bundle branch block after a TAVI procedure. Thank you.
Wow, thank you so much, Lars. That was a fantastic overview of a somewhat of a common problem, and I would say perhaps an Achilles heel, because many of us are very, very worried about the permanent pacemaker, and especially because you talked about that first piece of the impact of the patient outcome. So my question to you actually is, and my own feeling is maybe different than what has been portrayed out there. Is this about the patient or is it about the pacemaker? I believe that perhaps these are sicker patients. What do you think? Is it an independent predictor or is it just an association, true, unrelated? What do you think?
Yeah, it's difficult to say what is causing it, and it's probably a combination of it. But we also know it's different from different TAVI valves, how much conduction abnormality you're going to see after the procedure. But I think there's no doubt that permanent pacing of the ventricle in these patients is going to be harmful for the patient. And that's also why a lot of sites are discussing if the patient is of need of a permanent pacemaker, should you use a different pacemaker, not a conventional pacemaker, maybe CRT or HIS pacing if possible, to try to to preserve the ventricular function in these patients.
What I found fascinating about your talk was some of the planning and some of the techniques. Kendra, before this, we talked a little bit about using some of the computerized modeling in planning the type of valve. But what about what Lars just said? I think the computational modeling is even more exciting about how to align your equipment, as well as measuring the membranous septum. Those were really exciting. Are you guys doing that? And what do you think the future is in avoiding pacing by using these techniques?
I think that, yes, it's really, really important, actually, and it's become a priority for us. One of the major differences in outcomes between surgery and TAVR is this pacemaker rate. And some patients, especially younger patients, are very concerned about ending up with a pacemaker. So we started measuring the membranous septum, as well as trying to align our valves in the procedure to line up with the native commissures, so we have coronary access in addition to a high valve that's away from the membranous septum. And so some of the information that came out of the low-risk Medtronic trial was that there was a huge disparity between pacemaker rates. And those teams doing membranous septum measurements or the cusp overlap technique and opening up the membranous septum had single-digit pacemaker rates. And so if we can mimic some of the lessons learned from there, that's certainly important. And we adopted those almost immediately as soon as we were able to see that there was a difference.
Didier, what are your plan? How do you plan out? How do you avoid pacing? And what's your rate right now at Toulouse?
It's true that we, like most of the centers now, we aim at treating more patients. We targeted 2 days hospitalization. So we try to be quite selective. And if we have a doubt on the need for a permanent pacemaker, we do implant the patient. But we apply the same methodology of measuring the membranous septum length, assessing the presence of a right bundle branch block at baseline. And if we have any doubt on the occurrence of a slightly delayed conduction disturbance, we keep the patients more than 2 days. But within 2 days, the decision is made. And I have to say that we consider that there are differences in terms of pacemaker rates between devices, whether they be balloon expandable, self-expanding, or mechanically expanding devices. So the attention we pay to the selection is very important when we think that the patient is at high risk of conduction disturbance.
So very interesting, and I wanted to get to that exactly. Are there device-related differences in pacing, and is this technique-related or really device-related? Azeem, what do you think? Do you think that we could minimize the rate of pacemakers even in the devices where we know there's a higher rate of pacing?
Yeah, absolutely. I think, what Kendra mentioned, and we've seen this with a number of different studies, is that the rate of pacemaker implantation is definitely related to operator experience and height of implantation. So I think there are procedural factors that can optimize it. I guess the one part we haven't really discussed is the management of conduction disturbances when they do occur. We discussed, we want to prevent it, but unfortunately they still will occur. And I think another important variable in why we see such different rates of pacemakers is that there's such variability in how these conduction disturbances are managed at different centers. Some centers will wait 24, 48 hours, even with a patient with complete heart block, to see if it goes away, whereas the other centers will implant the patient on day one or on the same day as the TAVR. So I think we're still lacking a more consistent way of managing conduction disturbances when they occur. We do have a consensus document out there, but there are recommendations, but they all need to be validated.
No, those are really, really great points. I think we take away that number one, pacemaker is associated with higher morbidity, mortality. We want to try to get away from this and minimize the rate of pacing. And Lars showed us beautifully that the membranous septum length has an important should be important and should be part of the pre-planning, as well as using the double cusp overlay to better understand and this areocaudal position. And then the use of algorithms, as you said, to improve and enhance the rate of pacing, depending, especially those that are dependent on devices, and there are certain devices that are associated with a higher rate. I want to remind everybody about our poll on that we put out there. Please answer our poll because after the talk by Didier Tchétché, which is coming up next, I want to make sure that we answer the poll, and the poll is on should TAVI be the default strategy in patients with symptomatic severe aortic stenosis over the age of 75. So with that, I want to go to our next talk, and I'm proud to have Didier Tchétché here talking to you about the bicuspid aortic stenosis, and hopefully Didier will let us know the role of TAVR in this very important entity.
Thank you very much, Roxana. So it's my pleasure to give this overview in 10 minutes about bicuspid. So here are my disclosure. So what we know from TAVI, from bicuspid aortic valves, is that it's quite a frequent disease in the overall population. And in the TAVI core that we are treated, the frequency of bicuspid ranges in Western countries and Europe about between 5 and 10%. And as you can see, it's much more frequent in Asia. So it's quite a frequent disease, and it's a situation that we meet not on a daily basis, but on a regular basis when it comes to transcatheter aortic valve implantations. And we have very reassuring feasibility, safety, and efficiency data, but coming from retrospective registries. So let's talk first about clinical outcomes. I cannot be quite exhaustive because there are many registries, so I try to focus more on the recent data set that we have now concerning TAVI in bicuspid valve. And the first thing, if we consider the high-risk population, that is still the population that we treat regularly with TAVI, and we extract this data from the STS TACC registry, focusing on the balloon expandable platform. And it's very interesting because Raj Markar and colleagues made a propensity matching of close to 3,000 patients with bicuspid and tricuspid patients at high risk, tricuspid anatomy at high risk. And what they observed is summarized in that slide. So TAVI with a balloon expandable SAPIEN 3 platform in patients with a mean age of 73, so high risk, but still not excessively, with not a high age as compared to tricuspid patients. These patients, when they were compared to patients with a tricuspid anatomy, had a similar survival at 30 days and 1 year. But interestingly, there was a high likelihood of aortic root injury and conversion to open heart surgery when these patients had the bicuspid anatomy. And this is something that is very important to keep in mind, because it tells us that this is a more complex anatomy, and everything that we do may generate some specific outcomes. So it was very important, and this was the first time from this registry, that there was signals for potential increase in the stroke rate when we treat bicuspid patients with TAVI. So this is something that may impact the procedural steps. In terms of over clinical outcomes and hemodynamics, we had similarity between the bicuspid and tricuspid patients, and it was exactly the same thing for quality of life. Another study that is quite important, and that was recently presented at the ACC on a different type of patients. This time we talk about low-risk patient, and it comes from the Evolute low-risk bicuspid study. 150 patients with a robust academic setting, because there was a CT core lab making sure that all the patients were really bicuspid ones. And you can see that It's consistent with all the bicuspid registries. The most important, the most frequent phenotype of bicuspid is type 1 left-right in more than 70% of the population. So here are the main learnings from this Evolute low-risk study, bicuspid study. The first thing that we learned is that TAVI with a supraannular platform, because the Evolute Pro was the platform that was utilized in that registry in low-risk bicuspid patients with a mean age this time of 70 years, so quite a young patient, achieved excellent early results with consistent annular sizing. Annular sizing was the only method utilized in that registry, and that provides consistency in terms of interpretation of the data. High device success rate, 95.3%, low stroke or mortality at 30 days, 1.3%, and it relates to the lower risk profile of the patient, and very exceptional hemodynamics with EOAs above 2 centimeters square, a single-digit mean gradient, and no patient with severe or moderate to severe regurgitation. So the last study that I wanted to discuss is another study about low-risk patients. And this study was conducted by Ron Waxman and his team. It's a smaller cohort. It's only 61 bicuspid patients, but it's still a low-risk study. And it's interesting because it combines different types of devices. Ramakar, it was only about S3, with Basil, Ramlawi, and the investigators of the low-risk study, it was only about the Evolute. Here, it was 3/4 of S3 and 1/4 of Evolute. And you can see that the outcomes at 30 days were really exceptional with no mortality. It may be only a factor of the small size of the cohort, but it tells us that TAVI in bicuspid patients at low risk is safe. It's really safe. Still selected patient, but it's safe. With no patient with moderate or severe regurgitation. The only signal that we may extract from the study was maybe a significant proportion of patients with hypoattenuation, leaflet thickening, or leaflet thrombosis. So we have to maybe pay attention to that in terms of treatment of this patient. We're going to present in a couple of days the result from the Evolute X registry. That is something that is also prospective, and will provide more insights into the outcomes in contemporary treatment of bicuspid patients with the Evolute platform. Sizing is one of the point of controversy when it comes to bicuspid patients. And what we know is that we have to consider CT scan that remains the gold standard and utilize that scroll technique moving all across from the annulus to upwards to understand the distribution of the leaflets, the calcium. And what we do more and more on a daily practice is to compare the annular sizing and the supraannular measurement. At the supraannular measurement, you can utilize the commissure to commissure distance. We're going to see that. Or you can also utilize the supraannular tracing. And it's all about matching those measurements that you obtain to better understand what is the configuration of the landing zone. In the vast majority of the patients, the tubular configuration, but we can also have this tapered, Bavard type tapered configuration or volcano-shaped configuration that will tell us that maybe we should select a smaller device, be cautious in terms of pre-dilatation, post-dilatation, and so on. So it's really important to understand the configuration of the landing zone. From the Bavard registry, that was the MSTCT Focus registry, what we learned was first that the implant depth was about 3 millimeters for all the devices. Second, there is a constant under expansion of the stent frame when we implant TAVI devices in bicuspid valve. And this is something that we have to consider when we are in a gray zone. Maybe a smaller device is going to be more efficient because the bigger one will be too much undersized, underexpanded. And at last, quite reassuring, we observe a reshaping of the landing zone with more circularity after TAVI in bicuspid Latib valve with second generation devices. So a very, very reassuring data. In terms of procedural details, I'm not going to disclose all the items of the Evolute X registry. For those who are not really familiar with that registry, it's going to be 150 patients. with a CT core lab, echo core lab, clinical event committee, a single device, Evolut R or Evolut R34 or Evolut Pro. And when we extract the procedural details of half of the cohort, you can see that pre-dilatation was quite systematic. Repositioning was utilized to make sure that the final depth was appropriate. Post-dilatation was achieved, and from this interim analysis, we had no patient with moderate or severe regurgitation, and also, once again, large EOS. So this is achievable if we apply the proper technique from a procedural standpoint. So to summarize, what we can say about TAVI in bicuspid aortic valves, the first key message is that it's a really frequent disease, and you see that. So TAVI for bicuspid aortic valves with different devices is achievable, and it has demonstrated excellent clinical outcomes with very impressive hemodynamics, but still in selected low to high risk patients. We have to see in a broader cohort with maybe more complex patients. And it tells us that the heart team has to remain really central in that selection process because it relates to very exceptional outcomes. Sizing relates on MACT by combining the annular sizing, that is the principal method, but also putting it into perspective with the supraannular tracing, particularly in gray zone and in tapered, Barbour type tapered configurations. Also, TAVI for a bicuspid aortic valve, as you've seen, is technically demanding with several manipulation steps that are now standardized through the procedure, and we have to respect that. And maybe the use of cerebral protection devices could be something that becomes more utilized consistently in bicuspid valve, because that could be one of the issues, stroke post bicuspid. Thank you.
Wow. Thank you so much, Didier. That was a fantastic talk on a very, very important topic. So many questions in this arena because I think there's so much unknown, and I think that what you're doing with the Bivolute X registry is a fantastic way to actually study prospectively consecutive 150 patients, and we look forward for your presentation of that. But before we go there, I think one of the things, me as a clinician, when I see patients and they always are asking about percutaneous treatment for their valve with bicuspid valves, and with the fact that there is lack of data, I always worry about the aortopathy that's associated with patients who have bicuspid aortic stenosis. How are you evaluating that? And I didn't see you cover that. There is an association with, ascending aortic enlargement over time, et cetera. What are you doing to really choose the right patient for a percutaneous management?
It's true that this is one of the principal concerns, because we know that there is a strong association between bicuspid anatomy and ascending aortopathy. So if the patient is really inoperable or at high risk for surgery, we may select a shorter stent frame device to make sure that we don't interact too much with that diseased aorta, as for example, the SAPIEN 3 or the Lotus device. If the patient is at lower risk or younger, definitely it's a close discussion with the surgeons to make sure that we propose the appropriate therapy for the patient, and surgery still has to be considered. Aortopathy is one of the anatomical factors that should, to my opinion, still drive the treatment, the therapy towards surgery, even in intermediate risk patients.
No, I think I think we're going to be looking at this in a very different way and maybe evaluating our bicuspid aortic valve patients differently. Kendra, you as a surgeon, what's your view? We're invading, really getting into the surgical territory with bicuspid aortic stenosis and moving towards that. What do you think is the right way to approach these patients? And also to hear what Didier said about the aortopathy, and then are there patients that you believe should actually have percutaneous intervention for their treatment?
So I think that it's very individualized. He hit on a couple of key topics, and certainly the age of the patient plays a role in that decision making, the comorbidities of the patient. So if we have an older, frail, sick patient, a TAVR is probably all that they need. But when you do have a young bicuspid patient, let's say a patient in their 50s that already has an aortopathy, we have to be really discussing treating everything at once. There's a huge gray zone where the aorta does not yet meet criteria for replacement, but you can see that it's bigger than it should be. And if I'm not going to be replacing the aorta in the young patient, then maybe TAVR as their first platform is appropriate. But I think having that conversation with the patient, making sure that they are involved in that conversation, understanding that there will be could be additional steps is important. You know, the one thing also is that these patients do very well when they're young and have an aortopathy with a mechanical valve. And that has to be a part of the discussion. I'm certainly not going to push that on a patient, but they have to know that that's an option.
Yeah, no question. And I think this comes to you, Lars, who does a lot of randomized trials. When are we going to see a randomized trial? I think that's what we need. And I think in the right patient, it would be really a good way to proceed. What's your view on randomized clinical trials for this particular entity?
I think that's what we need, and we have seen TAVI works in these patients, also low-risk patients. But again, it's still elderly patients, and we expect it to move down to younger patients, to patients with longer life expectancy. So before we can introduce TAVI to younger patients with bicuspid aortic valve, we need to see a randomized trial between TAVI and surgery, and not only looking at short-term outcome, 30 days, 1 year. We need to see much longer term outcome, how it's actually going to perform.
No, I think it's absolutely fair. Azeem, any short comment? Because I never want to leave any panelist out of a conversation. I'm told I need to go to the live cases, but any short comment?
The only short comment I would make is that in low intermediate risk patients, you know, an important discussion, heart team discussion is important because many of these patients are operable and would be better be served by surgery.
Thank you. Thank you so much. Now, as I promised, we're going to show you the results of our first poll. So that's going to go live. And then I'm going to put up the next poll, and then we go to the live cases. Let's see the poll. Should TAVR be the default strategy? 81% of the 613 people in the room. Wow, we have 613 people in the room listening to this. And 81% are going with TAVR as the default strategy for patients over the age of 75. Thank you so much for those of you who responded. I hope we have answered a lot of your questions.